The next condition we'll talk about is conditions where potassium levels are low, that is hypokalemia. If potassium levels go less than 3.5, technically that is hypokalemia. However, the worrying point should be when the potassium levels are less than 2.5 millimoles per liter. This can happen if patients are on diuretics, or in certain situations like vomiting, diarrhea, intestinal fistulae, and glucose and insulin infusion if patient is having them for a different reason. Diuretics, particularly the loop diuretics, exchange sodium for or they are known to lose sodium and potassium at the same time. So patients can develop hypokalemia. And diarrhea and vomitings, because the amount of potassium in the intestinal secretions is high, so with each vomiting and diarrhea the patient has, more electrolytes are lost. That could be another reason why patient can develop hypokalemia. Glucose and insulin infusion, as I have described in the previous video of hyperkalemia, with every molecule of glucose, insulin drives potassium into the cells, and hence there could be a pseudo hypokalemia, but the potassium is going to come out later. So this is something we need to watch whenever we are supplementing potassium, why the patient is developing hypokalemia. What can happen if the potassium levels go less than 2.5? As we discussed earlier, potassium is an important ion in action potential. So if the potassium levels are coming low, then what happens is the duration of action potential increases. And when this happens, particularly in the AV node, what the AV node has is the action potential has got an absolute and a refractory periods, absolute refractory period and a relative refractory period. During the absolute refractory period, no matter however much stronger stimulus is given, a second stimulus will not be able to stimulate the cardiac muscle. Whereas during a relative refractory period, if a stronger stimulus is given, the heart muscle can be excited. Now this absolute refractory period gets extended, and the relative refractory period also will get prolonged in hypokalemia, and so a next action potential that is coming will not be able to be carried out. So in a situation where in the heart, particularly in the AV node, if SA node is firing, the sinoatrial node is firing at 70 or 80 beats per minute, the beats are coming to AV node, there is a small delay, and then the electrical impulses are passed on to the ventricles. This is called the AV delay. This AV delay is important because the way the heart muscle functions, atria have to contract completely, empty themselves, and the ventricle have to fill completely before the ventricular contraction starts. So that AV delay gives just that bit of an advantage where the atria can empty completely before the ventricle starts contracting. So AV delay is important in that respect. But in situation of hypokalemia, the AV delay gets prolonged more than what it should normally be. So the first beat comes, it gets transmitted with a delay of to the ventricles, but when the second beat arrives, it will still find the AV node in an absolute refractory period because of hypokalemia. And because it's an electrical impulse, if it cannot go on to the ventricles, it gets bounced off again into the atrium, and thus creating a circuitous rhythm which can tip the patient into atrial fibrillation. So one of the common causes of atrial fibrillation in the immediate post-operative period in cardiac surgical patients is because of hypokalemia, and hence you will find over your course of time whenever you are working in cardiac intensive care is that whenever a patient goes into a new onset atrial fibrillation, one of the first treatments we tend to look at is correcting the potassium and bringing the potassium up to 3.5 or at least 4 millimoles per liter, because unless we do that, no matter what other kind of treatment we give, the patient's absolute refractory period of AV node should be corrected so that other treatments can work and the patient can be reverted back into sinus rhythm. So that is the importance of hypokalemia in cardiac arrhythmia. So it can precipitate atrial fibrillation, and it can precipitate a particular dangerous tachycardia called torsade de Pontes in patients taking digoxin. So wherever a patient is taking digoxin or they have been on digoxin treatment, it is very important to ensure that their potassium levels are maintained adequately. If their potassium levels come down, then patients can go into this torsade de pontis, which is a dangerous ventricular tachycardia and which can kill the patient. So, and it is not uncommon that patients who are on digoxin are often on diuretics. Diuretics tend to cause hypokalemia. So, very important to instruct patients to consume potassium-rich foods, which are all citrus fruits. So, lemon, oranges, and pineapple and tea, coffee, they have high levels of potassium, and bananas, they have high levels of potassium in them. So when patient consumes these food as a routine, then the chances of them going into hypokalemia will be less and developing complications because of digoxin treatment will be less. So this is we are talking in an outpatient setting. But anyway, even if patient is on digoxin in ICU, or if they are in atrial fibrillation, always better to correct the potassium levels first and then to treat with calderon or digoxin again. Now, the ECG changes in hypokalemia are T-wave inversions and presence of U waves, which is an extra positive wave that comes. It's like after repolarization, and that is again secondary to the prolongation of repolarization phase because of low potassium levels. So, and low volume QRS complex, and if left alone, it can lead to atrial fibrillation. When it comes to treatment of hypokalemia, obviously the treatment is potassium replacement, and the best way it is done is in an ICU setting is by giving intravenous potassium. Intravenous potassium is it's again not to be taken lightly. If you notice, potassium ampules should be stored under lock and key, and they are not to be kept with the rest of the medication, because giving potassium fast can kill the patient immediately. So potassium infusion, potassium should be given as an infusion over a period of time, and the maximum potassium that can be given in an hour is 20 to 40 milliequivalents per liter. Now, in most instances, never give more than 20 milliequivalents per liter unless the potassium is so precipitously low, then you can go up to 40 milliequivalents per liter. But in clinical practice, normally what happens is potassium is diluted in normal saline, about 50 to 100 ml of normal saline, and it is given over 1 hour. So 10 to 20 milliequivalents of potassium should be given over 1 hour. Now 10 ml of potassium chloride has got 5 milliequivalents, so you can calculate based on that. And it is always a good exercise to look at the ampule and see how many milliequivalents each ampule has got before you prescribe and before you treat. It's a standard, worldwide standard, that this is how it should be. 10 ml will have 5 milliequivalents and 20 ml will have 10 milliequivalents. So when you are giving your instructions to the sister, you be very sure what you mean, 10 ml or millimoles, because over the phone or when you are talking rapidly, it might sound similar. So if you ask them to give 10 millimoles of potassium, if they hear as 10 ml, they would have given only 5 millimoles of potassium. So very clear instructions, always written instructions, and with a total understanding of the physician treating and with the nurse who should understand how much potassium should be given, and never to be taken lightly, always to be monitored. ECG should be monitored, blood pressure should be monitored, and potassium should always be given centrally only, because it can cause severe thrombophlebitis. So never give potassium peripherally. If a patient doesn't have central access, then the dilution of potassium should be much higher. So instead of 50 ml of normal saline, it should be diluted either in 250 ml or 500 ml of same 10 millimoles of potassium should be diluted in 500 ml of 5% dextrose or normal saline and given slowly over 1 to 2 hours. Never give potassium, high concentration potassium through peripheral veins, because that can cause thrombophlebitis, and potassium should always be given centrally. And one more reason why it should not be given fast is when you are giving it centrally, directly the potassium is going to reach heart, and if it is given fast, it can stop the heart and kill the patient. So it is a treatment never to be taken lightly. Now, how much potassium to be given for correction's sake? So if the potassium levels are less than 2.5, as I have discussed, and if the patient is in atrial fibrillation or if there is a clinical condition, then you can go up to 40 milliequivalents per liter. But this has to be prescribed by someone senior and overseen all through. But best case scenario, if the potassium levels are less than 2.5, give 20 milliequivalents of potassium over 1 hour in 100 ml of normal saline. If the potassium is between 2.5 to 3.5, give 10 milliequivalents of potassium over 1 hour. If it is between 3.5 to 4.5, there is no need to give potassium supplementation. If the potassium is between 4.5 to 5, then it is going on to the hyperkalemic side, then be prepared to go and give dextrose insulin. And if it is more than 5, inform your senior and take necessary precautions as has been mentioned in the hyperkalemia treatment. In a non-ICU setting where patient is on diuretics, or if the patient is recovered and they are on the ward, they don't have central line, the other way to supplement potassium is by giving oral potassium supplements. Potassium is very well absorbed from the stomach, and there is a solution called pot chlor solution, which is basically potassium plus chloride. So giving pot chlor solution on a regular basis can increase the serum potassium levels. But again, this treatment is not to be taken lightly. It should not be prescribed for months together, and because that can end up in hyperkalemia. So potassium levels need to be monitored on a regular basis. And the ideal treatment is to give 10 to 15 ml of pot chlor solution in either diluted in water or taken directly twice a day, or even better once a day if the potassium levels are not too low. Because again, more than twice a day should only be attempted in a hospital setting with ECG monitoring. If the potassium levels of the patient is precipitously low, then only consider 3 times a day. But otherwise, 2 times a day or once a day potassium supplements with pot chlor solution is the best way to treat hypokalemia. And whenever potassium supplementation is being given, either through intravenously or orally, it is very important to check renal function regularly, to check potassium levels regularly, and always check with seniors whether this is the correct modality of treatment or not. So we should all remember that potassium can kill, and check that you are absolutely sure that potassium is needed to be given before administering. And potassium should be stored under lock and key, and whenever potassium is being given, give slowly, and if you are not sure, always ask. Thank you.